Thank you, sir. Your expertise shown through. Thank you for guiding us. Now let's come to the next session. We now hand over to Dr. Jashnu Tople, sir, for the session on interventions in CRPS. Dr. Tople is the Director of Mitigate Pain Clinic, Nagpur, specializing in neuropathic and musculoskeletal pain, recipient of Young Pain Physician of the Year 2024 award. He has 18 publications and notable contributions, including a book chapter on pain management. Welcome, sir.
Thank you for the nice introduction. Okay, so my topic for today is interventions in CRPS. Initially, I will be focusing on the bit about the introduction, and then more focus will be on review of literature about MIPSs. So, CRPS has been known since more than a century and was first described by Surek as Sure's dystrophy. After that, in literature, there are more than 72 nomenclatures. And it was quite confusing, so IASP made consensus meeting in 1993 in Orlando and coined the term complex regional pain syndrome. And they defined it as a collection of locally appearing painful conditions following trauma, which chiefly occurs distally and exceed in the intensity and duration than the expected clinical course of the original trauma, often resulting in considerable restriction of motor function. Usually, only one extremity is involved, and the incidence is about 5 to 26 per 1 lakh population. And women have more preponderance, about 4:1 from female to male. Clinical features are variable. Important is there should be continuous pain, but there can be combination of sensory dysfunction, vasomotor or pseudomotor dysfunction, and motor and trophic changes can be there lately. It is usually preceded by trauma or surgery, but not necessary always. And mostly it appears like glove-like appearance in arm and sock-like appearance in leg. There are n number of differential diagnoses depending on the presentation at the point of time the patient is presenting to you. And based on that, you need to investigate the patient just to exclude your differential diagnosis. There is no specific test to diagnose the CRPS. However, n number of tests have been described in literature which are primarily used for scientific research. So it was quite difficult based on everything to diagnose the CRPS. There was no diagnostic test. There are no specific clinical things. So initially IASP in 1994 described criteria popularly known as IASP criteria, which were then inconsistent and have had a low diagnostic rate. So after that, Budapest criteria came into scene and was validated by IASP in 2012, which says that there should be at least two things. One is continuous pain disproportionate to the inciting event, and patient should have at least one symptom in all of the category and one sign in two or more of the categories of sensory, vasomotor, pseudomotor, or motor and trophic changes. So coming to the conservative management, goal of the conservative or MIPSs is to improve pain relief, physical function, and psychological well-being, and to help patient to regain the quality of life. The mainstay of treatment is physiotherapy, which can be supported with pharmacotherapy, psychological support, and occupational and vocational rehabilitation. Among pharmacotherapy, depending on the which part is involved, whether it is only pain and inflammation, whether there is involvement of vasomotor or motor dysfunction, pharmacotherapy can be modified based on the presentation at the point of time. When the conservative management is not working, then we go to the MIPSs. There are n number of interventions which can be done for CRPS, including most commonly sympathetic interventions, then peripheral nerve blocks, and sometimes we need to go for central neuraxial blockade and neuromodulation. So coming to sympathetic intervention, these are historically most commonly done, are important for the diagnosis of sympathetically mediated pain. Sometimes CRPS can be independent of sympathetically mediated pain. So these interventions might not work in those patients. We need to keep in mind that. The success rate usually depends whether is higher in patients who have mechanical and thermal allodynia. However, if patient has anxiety, it can negatively affect the outcome. So a study published in 2003, it was found that the outcome were better if amitriptyline was given along with the sympathetic blockade. Stellate ganglion block was also studied for CRPS 1 patients in 25 patients, and the authors found that there was inverse relationship between the hand perfusion and the duration of CRPS symptoms. And there was a positive correlation between the efficacy of stellate ganglion block and how soon it was initiated. In another study published in 2000 it was retrospective analysis of 86 patients, and they found that radiofrequency ablation for stellate ganglion was successful in 14.7% of the patient, but 4.7% of the patient showed worsening of symptoms. So whenever we are intervening with these sympathetic interventions, we need to keep in mind that there can sometimes be worsening of the symptoms. Then coming to lumbar sympathetic block, it was found that cutaneous toe temperature, when increases more towards the core temperature, it gives indication towards the successful sympathetic block. Then about the outcome, in a retrospective study, it was found that the duration and degree of pain relief was not associated with the pre-procedural temperature. And in that, the authors also mentioned that the success of sympathetic block doesn't go hand in hand with the success of spinal cord stimulator. There were conflicting results whether the chemical neurolysis should be used or radio frequency should be used for lumbar sympathetic. And number of studies have variable results. However, it was found that there were, in most of the studies, it was found that there was no statistical different outcome between RF and neurolysis. But the neurolysis is associated with the more complications like neuritis. So RF treatment is preferred over the neurolysis. Also, botulinum toxin injection was tried with sympathetic blockade, and it was found that the it gives a prolonged duration of pain relief when Botox was added to the local anesthetic for lumbar sympathetic block when compared with the only local anesthetic. Also, botulinum toxin have been tried with 75 units, and it was found that the increase in temperature was higher in botulinum toxin than the control group, which was local anesthetic group, and pain relief was also better. Botox was used in 20 to 190 units and was found to have direct analgesic effect in patient with chronic neuropathic pain. And coming to the neuromodulation, and neuromodulation can be done in various ways, as we all know about most commonly spinal cord stimulator, peripheral nerve stimulator, or DRG. And data demonstrate that the pain reduction or improved quality of life and function and reduction of the opioid is associated with the neuromodulation techniques. However, it should be kept in mind that peripheral nerve stimulator is only possible when there is involvement of single or two peripheral nerves only, and it is less suitable for CRPS1. So coming to the evidences for spinal cord stimulator, evidence suggests that it is effective in chronic neuropathic pain of FBSS and CRPS1. In CRPS, it attenuates the T cell activation, improves the peripheral tissue oxygenation, and decreases the anti-angiogenic activity, which results in the endothelial dysfunction and improved blood flow. DRG stimulation was studied in a pooled analysis, and it was found that in CRPS1 patient or causal GR, the reduction of pain intensity was about 4.9 and 4.6 respectively. In another study, which is accurate study, a very renowned one, where authors found that the percentage of subject receiving more than 50% pain relief and treatment success were greater in DRG in patients who are receiving DRG stimulator and compared to the spinal cord stimulator. So also it was found that the DRG stimulation demonstrated better improvement in quality of life and psychological disposition. Subjects using DRG stimulation reported lesser postural variation in paresthesia, and there was reduced extraneous stimulation in non-painful areas, indicating that DRG stimulation provides more targeted therapy to painful parts of the lower extremities. So might be we can move from spinal cord stimulator to DRG in coming years. The peripheral nerve stimulation, not very well studied, but there are few studies mentioned that the 43 patients have used the permanent stimulator implant and had lasting and good success. In another study published in 2007, it was said that over 60% of patients had a significant improvement and lifestyle following the implantation. But it should be noted that 40% patient had a failure rate, and it is significant in real clinical practice. Then coming to the peripheral nerve block, brachial plexus block has good outcome to tolerate the physical therapy. It blocks the sympathetic nerves around it, and it can be used if the sympathetic blockade is failure. So brachial plexus block, interscalene block was studied with the stellate ganglion block, and it was found that interscalene block was at least as effective as stellate ganglion block for the treatment of CRPS. Then axillary block was also studied for CRPS, and it was found that the patient-controlled analgesia provides very good outcome for CRPS1 patient for upper limb. Also, the clonidine was added in that, and clonidine has been found to have very good outcome with the 300 microgram dose or 700 microgram dose, but the higher dose have a higher rate of sedation. In one of the case report, it was found that the early treatment with the continuous epidural analgesia gives promising outcome in patients with CRPS. Intrathecal administration of the drugs, obviously you have morphine, baclofen, and ziconotidine, which is FDA approved for intrathecal administration with the IDSS system, and bupivacaine can be also given, though it is not still FDA approved. In 15 patients studied for the IDSS, it was found that the intractable pain of CRPS, arachnoiditis of the spinal injury, and chronic back pain of unknown cause, the patient had significant relief with IDSS. Intrathecal bupivacaine infusion was also studied in CRPS1 patient in a case report, and it was found to that alleviate the refractory pain, but it affected neither the associated symptoms and signs of CRPS1 nor its natural evolution. And hence, the intrathecal treatment cannot be recommended in preference to other pain treatment regimes of CRPS1. In patients, in intrathecal baclofen was studied, and it was found that the dystonia, pain, disability, and quality of life all improved with intrathecal baclofen infusion and remain efficacious at least for one year period. In another study where the intrathecal efficacy of baclofen was studied, and authors found that there was significant improvement in pain at least for 6 months. And after this period, the scores level reduced despite the further improvement in dystonia and continued intrathecal baclofen dose escalation. Ziconotidine also studied, but as not available in India till now, so let us keep it. And intravenous regional anesthesia has long been studied, and guanethidine was the first drug which was studied. Now it is not recommended to use, but other drugs like lidocaine and clonidine has been found to be beneficial in most of the studies. So this was all about the adult patient, but what about the pediatric patient? Data for pediatric patient is quite less. The recently published literature review in 2024 found that n number of interventions can be tried in pediatric patient, but overall there was a lack of high quality evidence, and nothing can be specifically recommended one intervention cannot be specifically recommended over the another intervention in pediatric population. Coming to the clinical practice algorithm which was given by World Institute of Pain, when your conservative treatment fails, start the psychological support. You should administer sympathetic block. If sympathetic block is positive, we can go proceed with the radiofrequency ablation. If sympathetic diagnostic block fails, then central neuroaxial block or peripheral nerve blocks can be tried. If both sympathetic blocks and central neuroaxial or peripheral blocks are not useful, then we can go for the spinal cord stimulator. In another consensus study which was published in 2022, they have also given their own interventional treatment algorithm, and where they have suggested that minimally invasive treatment like sympathetic, IV regional blocks or somatic blocks should be tried first. If those are not working, then epidural or plexus catheter placement can be tried. or neurostimulation and intrathecal drug delivery system can also be tried. If those are not working, though the evidence is not very good for sympathectomy and it can be tried, motor cortex stimulation is still under the study. So these are all experimental things. The level of evidence which were given by WIP in 2018 says that we have moderate evidence for spinal cord stimulator and DRG for lower limb CRPS. We have weak evidence for thoracic block with local anesthetic and triamcinolone, as well as IV ketamine. And we have very weak evidence for peripheral nerve stimulation. And sympathetic blocks with local anesthetic do not have any evidence. Also, intravenous regional block with guanethidine must not be used, but local anesthetic and clonidine can be tried as an experimental basis. So to conclude, considering the complex pathophysiology of CRPS, there is no gold standard treatment for it. Depending on the presentation, we can consider for the treatment of it. Try with the simpler, lesser invasive, lesser dangerous and lesser expensive interventions first. And if they are not working, we can go for more invasive, more experimental, and more expensive techniques. These are all my references. Thank you.
Thank you, sir, for your different modalities, discussing the different modalities of treatment. And there is shortage of time. I think there will be much more questions.
Thank you, ma'am.
It will be discussed after some time.
Thank you, sir. I think after the precise lecture from Jeshnu, sir, on the interventions in CRPS, all our doubts on CRPS interventions are vanished.